So we've got a lot to cover here today. So I want to welcome you to today's Vice President for Health Sciences Research Symposium. And as we are entering into this beautiful summer here in Buffalo and in June, we're really reminded of how important and just having an equitable society is. With both Juneteenth coming up around the corner and Pride Month, the school is really celebrating the diversity and the resilience and the unity within our communities. Today we have a great program. I'm going to go a little bit off script and just give a round of applause for Dr. Jill Cizek, who puts this together. So Jill put together an amazing program. It's focused on health equities, features about experts in minority health and disparities research, and we're really, really grateful. I'm going to walk through and give a little bit of a snapshot of our speakers today. The first is Dr. Monica Webb Hooper. She's Deputy Director of the National Institute on Minority Health and Health Disparities at the NIH. She brings extensive expertise to the symposium. Her work is in minority health and cancer-related disparities research, and that underscores her commitment to advancing health equity through innovative approaches. And I think some of you know that we had Larry Tabak here in the building giving us talk on Saturday, who was the former interim director of the NIH. So, and he was thrilled to know that Dr. Webb Hooper was speaking to us today. Dr. Webb Hooper's research spans across diverse populations facing health disparities. She's pioneering culturally specific interventions that have achieved long-term success. Her contributions have been many and brought significant changes to the field. We have two other prominent advocates for equal access to preventive care. Kelly Wolford, here she is, sporting her green and white tennies. We are so thrilled to have you here. And then we also have Dr. Karabi Achara. First, I'm going to tell you a little bit about Kelly. Kelly Wolford is the Director of Health Equity, Erie County Department of Health. You might have seen her interviewed in the Buffalo News about 10 days ago. It was excellent. She's a seasoned veteran in the field of health community engagement. She's a passionate advocate for eliminating health disparities in the Black communities across the 5 Buffalo zip codes. We're honored to count her among the UB Community Health Equity Research Institute steering committee. She also spearheads the mental health advocacy initiatives for the Buffalo Center for Health Equity, and her dedication and expertise are very much appreciated. And lastly, we're welcoming Karabi Achara, whose work focuses on understanding global health equity and challenges and integrating solutions to build a culture of health in the United States. And as everyone knows, that is the mission of the Jacob School, is to improve the health of Western New York and spearhead that across the entire country. Dr. Achara is a dedicated member of the Robert Wood Johnson Foundation team, where she leads efforts in understanding global health equity challenges and integrating solutions to build a culture of health. She has extensive background in public health, and she will bring invaluable insights and expertise to our discussion of advancing health equity in our community. We're privileged to have her join us as well as we explore innovative strategies. So now I'm going to turn this over to Kelly Wolford, and we are incredibly grateful for her participation, for our other organizations like the Community Health Equity Research Institute, the Center for Urban Studies, the Buffalo Center for Health Equity, all of which contribute to a community that is working together and is passionate on this topic. So, Kelly?
I presume that I should get started. You can all hear me, I hope.
Yes, thank you so much, and thank you for being here.
Thank you, Dr. Brashear, for the really kind introduction. And of course, I have to thank Jill Cizek and the Symposium Planning Committee for this invitation. It really is an honor. And I appreciate especially you allowing me to participate virtually. As you might imagine, things are very busy, so sometimes it's hard to make the trip, but I'm happy to be able to contribute. Agree that you have a really phenomenal agenda planned for the meeting. So happy to help contribute to the discussion, and pleased to see that these conversations and work are taking place in the Buffalo area. So just to give a little bit of orientation, NIH is part of the department, the U.S. Department of Health and Human Services. This is a sister, we are a sister agency to FDA, CMS, CDC, and the other organizations that you see here that you may be quite familiar with. NIMHD, my institute, is the newest of the, we say 27 NIH institutes and centers. It's 24 institutes and 3 centers. And NIMHD is the newest of the institutes. We became an institute in 2010 with the passing of the Affordable Care Act. So we're just 14 years into being an NIH institute. And we know that the problems around health disparities are just not new. We know that they're long-standing, that they've existed for decades, centuries before they were studied, or we had this term to help us define them. We also know that it's a cross-cutting area of scientific study that began really in the 1980s with the Heckler Report. And although there has been some progress in some areas, we know that there's a lot of work to be done. And so the mission of NIMHD is to work across NIH, work across the Department of Health and Human Services in a more general way to advance the science of health disparities and move us closer to meaningful progress. And given that this is a cross-cutting issue, health disparities and minority health issues overall, NIMHD is disease agnostic. So we do our work by supporting cutting-edge science in multiple areas across disciplines. And we have a strong emphasis on training and the development of a diverse scientific workforce. And we also focus on communicating findings to our partners through collaborations. And we're a small NIH institute by NIH standards. And so collaboration is really at the core of what we are doing. And I want to say something, since you're talking about health equity, I think it's important to level set and define health equity the way that we think about it at NIH and NIMHD. Equity is synonymous with fairness, opportunity, equality, social justice. Health equity is not an outcome. It's not an outcome that we just reach and we're done. Health equity is an assurance, and it means that we go out of our way to ensure that everyone has these optimal opportunities to attain the best possible health. And so it's not easy work, because many times a true equity framework would center itself around fair opportunities, around social justice. And many times that means that we're changing laws, we're changing policies, norms, values, how we allocate resources, and how we adjust power structures, and how these things all impact access to healthcare and the adverse social determinants of health. So, it's really important, and it's very broad. And most of what's happening, even though health equity has kind of become this buzzword, most of what you see happening isn't actually health equity work, because it's a much broader issue than what many of us have within our domain of influence even. But we're doing work to hopefully inform health equity and to assure that we're doing everything we can to go out of our way so that everyone has these opportunities to optimize their health. And so we did, Eliseo Perez-Estable, who is the director of NIMHD, and I published this commentary on this topic. We published it in the journal Health Psychology, and really it was to highlight the way that we understand health equity, to underscore our commitment to the advancement of health equity, and describing specific efforts in the diversity, equity, and inclusion space, which is workforce, and then distinct from that are scientific initiatives. And we really try to underscore in this commentary that it's not possible to get to this assurance of full health equity without confronting and addressing health disparities in meaningful ways. And so in the article, we highlight a few interrelated and actionable strategies in a very brief way that we can implement in order to help us assure health equity for all. So I do encourage you to read the commentary. This picture was actually from some work that I did before I joined NIH, I was a professor and faculty member, most recently at Case Western Reserve University. And we were conducting this, this picture was taken from a study we were working on in our community, and it was in a barber shop. And so the gentleman that you see to the right, I'm the tallest person there next to the guys. And so they were barbers who work with us on this initiative. And so I've been very invested in community engaged science and doing it in a real way, in a culturally competent and humble way for my entire career. So as I continue to talk about this, I also want to offer a definition of health disparities. So I actually think that health disparities and health equity and health inequities, I should say, are pretty interchangeable as well. Because when you talk about a health disparity, you're not just talking about any differences between any populations. These are very particular types of health differences, and specifically, they are rooted in disadvantage. And that's what the inequity piece is. Multiple levels, social, economic, environmental. The population to experience health disparities are those who have faced these systematically greater obstacles to optimal health. We can characterize them in a number of ways. We focus on race, ethnicity, and socioeconomic status as sort of the pillars, and the efforts that have stood up this area of science has been focused on those major issues. We also are looking at intersections with gender, sexual orientation, and other characteristics, again, groups that are often discriminated against or excluded. Now, the important point, or one important point that I'd like to make, is that health disparities are modifiable and do not have to exist. So if you're ever looking at a difference between two groups and a question about whether or not this is health disparity science, is are we studying modifiable differences that don't have to exist? And thus we have the opportunity to understand and address those issues. Here are the groups that NIH has designated as US populations that experience health disparities. So the groups include all racial and ethnic minoritized groups, socioeconomically disadvantaged populations, irrespective of other characteristics, underserved rural populations, and sexual and gender minoritized groups. And we know that these populations have experienced and continue to experience a disproportionate burden for the conditions that you see listed here and many others, unfortunately. Now, the patterns do show, in terms of disparity patterns, they do show some differences across the groups. But the main issue is that these disparities are longstanding, except for COVID-19, right? That's the one that we watched roll out in real time. And for many people, was like the first time they really saw this happen. But we know that there has not been enough measurable progress, and many of the factors that increase the risk of severe outcomes are preventable or addressable. And we all are no doubt familiar with studies concluding, right, that people of a certain race or ethnicity are at greater risk of negative behavior or adverse health outcomes compared to individuals from other racial and ethnic groups, without further investigation into the source of these disparities, and often say, well, we need to do more research on that. It's just a note in our limitations section. We need to do better than that to really get at these issues. So a few specifics based on recent data. There's often a lag with these, publicly available data sets, but these are among more recent data showing where we stand relative to all across racial and ethnic groups. So here you see mortality from heart disease, and you can see higher mortality. These are age-adjusted death rates. Particularly, we see higher mortality among Black or African-American patients. We also see really high mortality among Native Hawaiian and Pacific Islander patients. And so, as a matter of fact, if you look at these numbers between 2018 and 19, Native Hawaiian Pacific Islander patients is the only group to have increased mortality from diseases of the heart overall. These are data on diabetes mortality in the United States, where we also have higher rates among American Indian and Alaska Native communities, Black or African-American persons, and Latino and Hispanic populations compared with white and Asian groups. So we'll look at cancer. So cancer is an area where there's been a lot of focus on health disparities. And if you look by race ethnicity, we know that African-American or Black adults have higher mortality for most cancer types. Breast and prostate would be two very well-known examples. Hispanic or Latinas have higher rates of cervical cancer compared with women of other racial and ethnic groups. And this is these are national sort of data. So when you look within your catchment area, you may find differences in these patterns of disparities. But overall, we know that Asian American adults or Pacific Islanders also have disparities, in this case, in liver cancer prevalence. American Indian, Alaska Native adults have the highest rates of kidney cancer deaths and liver cancer prevalence. When you look at rural Appalachia, you also see significantly greater incidence rates of colorectal, lung, cervical cancer compared with urban areas. And in the final example here, individuals of less privileged socioeconomic status face greater colorectal and lung cancer mortality compared with people with a higher socioeconomic status. So understanding health disparities, addressing health disparities, really complicated topics, and that means that it creates complexity in fields of scientific study. And most of the research to date has either sought to identify, or I'd say secondarily, describe factors that contribute to health disparities, or what I call sort of first and second generation health disparities research. I want to get back to that in a little, but just to give you another example, when we think about causes, lung cancer is as a disease for which there are well-established disparities. Racial and ethnic minoritized persons who are diagnosed with lung cancer face worse outcomes compared with white persons. And at the root of these outcome inequities or disparities are not in genetic or genomic differences or any other biological factor, or inherent biology, but because of issues such as lower likelihood of early diagnosis and a lower likelihood of receiving surgical treatment, and that minoritized persons are less likely to receive any treatment. And this figure illustrates that these are true across the board among Black or African American patients and among American Indian and Alaska Native patients who were then less likely to survive 5 years out compared with white patients. Latino or Hispanic patients are also less likely to be diagnosed early for lung cancer, and they're also more likely to receive no treatment. And their survival 5 years is about 15% lower likelihood of survival compared with white American patients. So how do we continue to try to make progress and really make meaningful change in improving these persistent disparities? This is the NIMHD research framework, and it reflects how it's an evolving conceptualization of factors that are relevant to how we understand and address the issues around minority health and how we address and understand and try to reduce these health disparities. So a couple of points here. Most of the research, as I mentioned a few minutes ago, has focused in science and medicine, has focused on individual level biological mechanisms, so that purple box, or they focused on individual behavior highlighted in green as kind of how we explain poorer health among minoritized groups and for disparities. But as you can see, if you focus singularly on biology or genetics or individual behavior, you miss the great complexity of understanding and addressing the many other factors that should be considered. And these are broad categories of relevant factors that have other domains of influence, such as the physical, built environment, sociocultural environment, the healthcare system. We're also not thinking about the other levels. This is not just the individual level. There are upstream factors that are beyond individual control that also are playing important roles. So we are trying to encourage investigators to think more holistically and study the same way. One more note I would like to make about this framework is when you look at this model, you will note that it centers racism and discrimination as notable factors that affect minority health and health disparities across all of the levels of influence. It's just a part of our sociocultural environment. And so we have a program announcement that is seeking applications that study how racism and discrimination at the structural level impact health and health outcomes. I also want to make sure you all are very aware, speaking of, are we making progress and where are we? You might remember this landmark report that was then conducted in 2003 by the then Institute of Medicine, now the National Academies of Sciences, Engineering, and Medicine. And so NIMHD commissioned, along with other institutes and centers and AHRQ, we commissioned the National Academies of Medicine to update this 2003 report 20 years later. And so the project is aptly titled Unequal Treatment Revisited. And so we've charged a committee of experts to revisit the status of racial and ethnic health and healthcare disparities in the US, to identify interventions that have been successful as well as unsuccessful, and revisiting the recommendations from that 2003 report, which is still being cited. So hopefully this report will allow us to be able to update our citation in this space and really also help us identify the way forward, areas of either stagnation, widening of disparities. So this report will be released this summer. At the latest in early September is what the estimate that I'm getting now, but this is a high priority activity. And the 2003 report is still hugely impactful. So revisiting this work is hopefully going to have that impact again and set us on the right path for the future. So look out for that. Now, as we talk about these issues, it's really important that we get to the root. Why do all of these problems exist? What is, if anything, can we do about it in the research space? I think in recent years, really since 2020, there's been elevated recognition of the roles of adverse social determinants as root drivers of health disparities. So this is the NIH definition of social determinants of health. Another word that I think we have to be careful about things becoming buzzwords, because then they sort of lose their meaning, right? But social determinants of health are not negative per se. They don't have a valence, and they are distinct from health disparities, although sometimes you kind of get the sense that people are using them interchangeably in discourse and in literature. Social determinants of health are conditions and structural factors that shape daily life, whereas health disparities are these preventable differences due to fewer opportunities to achieve optimal health, as we talked about earlier. So both of these, like health disparities, social determinants are also modifiable and don't have to exist. So saying this another way, social determinants of health can operate in more than one way. They can operate to drive effective health promotion and well-being in advantaged groups, such as living in a neighborhood with clean air, with clean water, with great public school systems, with beautiful parks and green spaces, appropriate social support, individual, family, and community. They can also drive health problems and undue burden, or what we know of as health disparities among disadvantaged groups. So that's why I refer to the factors that drive health disparities as the adverse social determinants of health. And the goal is for everyone to have positive and protective social determinants in their lives consistently. I also should say something about measurement in this space. The old adage is it's hard to improve what isn't measured. And I think the new adage is it's hard to improve also if we're not all measuring the same thing. So to that end, we've worked to curate a resource, an electronic resource called as part of the Phoenix Toolkit, which is a longstanding resource that provides content, and it provides what they call protocols, but it's really like measurements, instruments, data sets. We want to move to intentional and consistent standardization of how we collect data so that we can speak across studies, we can combine and harmonize data, would really promote our reviews and our meta-analyses and help us understand if we're making progress in various areas. So within the Phoenix Toolkit, NIMHD curated a special collection that's called Social Determinants of Health. And we are encouraging investigators who are conducting human participants research to utilize this collection. Now, I realize, as a former PI, everyone has their favorite measure. They have the way they've been assessing these constructs and the instruments that they've been using for many years. We're asking for a bit of a shift so that we can all begin to collect data the same way. So in this collection, there's a core collection, and then there are individual collections. So just to share with you what's in the collection. So if you were to go to that website, you'd be able to look and click on the Phoenix Toolkit SDOH collection. You would see the measures that are in all these collections. In the core collection, there are 16 measures, basic demographics, which are not social determinants, but then also you have social determinants of health, access to health services, food insecurity, health literacy, occupational prestige. And these measures are deemed very relevant to all human participants research. And then we also have the special collections, and we have them at two levels. So we have the individual specialty collection, and these are measures that are used in research where we're collecting self-reported data. So people are answering for themselves, perhaps a family member or caregiver, but it's for individual respondents. And then you have the structural specialty collection. So if you're interested in looking upstream, These are measurements and data resources that are often from publicly available data sources at the structural or community level. And you can combine and look at and link your data to look at things from, for example, from the US Census or from the American Community Health Survey as an example. So I was asked to focus on the community engagement piece of all of this and community engaged science, which is very important. And I think indeed it should be a thread that runs through your entire program and all of your projects rather than being kind of an afterthought. And in my experience as a PI for many years, I'm well aware that that community engagement piece, which sometimes can be required for funding, can easily be just like window dressing. It's not real. And so I'm very pleased that this symposium is focused on health equity and community engagement to hopefully prevent the infamous helicopter research that has disappointed many communities who've partnered with researchers in good faith. And I'll also just note that community outreach and engagement and community engaged research, it really is important for all kinds of work, even basic scientists who sometimes don't necessarily quite see how they fit in. And when we think about community and engagement and partners and members in the research enterprise, there are many benefits to these kinds of approaches. So community engagement activities designed to establish, long-term relationships with community-based organizations is important for thinking about the long game and being able to assess change over time. It's also important that we build the mutual trust that you hear so much about, but very little details on how you actually do that. But it's important to get there to address health-related concerns. And also, although it's not the purpose, say that again, not the purpose of community engaged research or community engagement to use it to promote participation in research and recruit people for your study. It's not the reason. But real, authentic community engaged research and community engagement, which are different things, they do serve to promote participation in research, retention, and it's also, of course, important that we translate and disseminate our findings to the community. Now, just to point out that COVID-19 was an area that really put a spotlight on all of this and really highlighted the need to conduct community engaged science and utilize culturally appropriate and community competent strategies. And so NIH really has been at the forefront of this effort. And so this was a viewpoint that Eliseo, Anna, and I published in 2020. I started at NIH in March of 2020, so like literally when the pandemic started. And this was the first article I wrote. We started to see very quickly the disparities that were emerging in some of our cities. And it was really data that was available just on like public health department websites. And we issued a call in this commentary for community engaged science, knowing from longstanding experience that diverse and equitable partnerships across sectors were going to be central to decrease the detrimental impact of COVID-19. And so to address these needs, NIH jumped in right away, launched several large-scale initiatives that were community-centered. These are two of the largest ones. One is the Community Engagement Alliance Against COVID-19 Disparities. Now it's just the Community Engagement Alliance because we've broadened to focus on other kinds of health challenges. And then the Rapid Acceleration of Diagnostics Underserved Populations Initiatives. So these two NIH-wide initiatives really exemplify how NIH collaborated with communities to improve health. So I want to tell you a little bit about these projects. So SEAL was established in the summer of 2020 to focus on reducing COVID-19 disparities. We now have strong partnerships with community members, leaders. We have over 500 community partners involved in this initiative, 23 geographic locations, and the partnerships are multi-sectoral. And everyone's been working together. It really started off focused on clinical trial inclusion, meaningful information about COVID and addressing misinformation, awareness, education, those kinds of things, using a variety of culturally appropriate resources and educational tools, both technology and a really strong ground game. Now, so SEAL really was founded in several guiding principles, the first of which is that mantra of moving at the speed of trust. and also working on building and sustaining the trusted relationships and working with people who are trusted voices and messengers locally, but doing so in a way that they don't feel like you're using them for that. But it's important that we have their context expertise in addition to our content expertise. So the SEAL initiative is still ongoing, and it's moving into its 4th year and focused on a number of social determinants and other risk factors for health. And first and foremost, SEAL is about partnerships. And here you can just get a sense of some of the accomplishments of SEAL over this time. You know, we've had a large emphasis on health communication and science communication. And how do we do that at multiple levels? And so these are just some examples of what these SEAL teams have done. There are 21 teams working in 23 geographic locations, and they've engaged millions of people and over this time, and assisting people who were interested in being vaccinated for SEAL, and really to understand vaccine hesitancy. So this is an ongoing effort that NIMHD is very, very strongly invested in. The second one, the RADx, Underserved Populations Initiatives, it was one component of a RADx initiative, which was focused on developing tests or COVID-19 tests and diagnostics. And this was a part of the initiative that was focused on already FDA cleared, authorized, approved tests, and how do you bring those into populations that experience health disparities. Also very rooted in partnerships, working across settings, across different kinds of communities like urban and rural communities, working in schools, community health centers, correctional facilities. This initiative has over 350 partners, and they are promoting access and uptake of tests for COVID-19, evaluating interventions. This intervention, as you can imagine, we're in the 4th phase. We have a couple of projects that will look at implementation of tests and how we can make sure that, even because COVID is sort of part of what we think about and deal with, and it's here, but we still have to be tested. And how do we get people to continue to do that as needed? And it was rooted in the guiding principles, community centered in the work. This is RADx Up. RADx Up touches all of the states, Puerto Rico, and a number of US territories in terms of where we've been engaging participants and have administered over 400,000, almost 450,000 tests at this time. So here are a few thoughts about what we've learned from all of this. I think these initiatives, both of them, SEAL and RADx Up, have been successes, I would say. And I think we can attribute the success to the full partnerships with the affected communities. Here are some things that we have thought about and focused on. We have to make sure that we are addressing the concerns together, deciding on the research plans. The partnerships really need to be authentic and genuine and based on mutual trust and benefits, and appreciating those complementary skills that academic partners and community partners come to the table with. And I always start with the fact that everybody wants to be as healthy as possible as our starting point. And we also learned from this that we can quickly get out there. I mean, these teams were in the field very quickly in the pandemic while we were all social distancing and remaining at home as much as possible. These teams were able to quickly deploy COVID-19 tests, PCR, and then self-administered, home tests, and also encouraging the use of mitigation strategies using culturally appropriate methods. So we had to consider lots of things, social and ethical issues along the way, such as the distrust that was there, that was reasonable. How do we deal with consent, data sharing, and other sorts of behavioral factors? And some of the other things we learned from RADx Up in terms of intervention. So RADx Up delivered these testing interventions to understand what are the best strategies to do this. And we learned several things about what interventions were successful and what has been less successful. We just published in the American Journal of Public Health at the end of last month, a special issue focused on RADx Up. It's our second special issue to really bring and disseminate some of these findings within the academic community. But we see that the successful interventions for increasing COVID-19 testing, access, and uptake in these populations have involved a variety of strategies. I think we can see that if the projects are community-centered and engaged, if they delivered culturally specific messaging, if they made efforts to address systemic barriers, if they leveraged local trusted voices in various settings, those were important for the interventions that we saw showing some success. When you look at the interventions that were less successful, these tended to be more on the top-down communication. And we saw this just, I think, not even in research, but even within at a national level, the way we communicated about COVID-19 with sort of generalized public health messaging from government agencies without adaptation to local context, and that is less effective. So if the messaging, does not consider local beliefs, norms, languages, it tends to be less effective. We also see that interventions that do not involve community representatives in the planning and implementation stages may fail to address key community-specific barriers. Relying on only one kind of outreach, like maybe just digital media as an example, can really miss segments of the population that have less access to technology. Some people, think, oh, because we use technology for everything that everyone does, when in fact there still is a bit of a digital divide and certainly digital inequity in terms of being able to utilize these technologies that still exist. Interventions that don't consider, that heterogeneity within populations, those can be ineffective because there's such a variety of lived experiences and needs. So standard approaches just may not resonate with all members of a community. And then lack of follow-up and support. We also saw that testing programs that did not offer support for individuals who did test positive, such as, information on isolation, treatment options, financial support, those can be less effective as well. So that, and the kind of clear linkage to wraparound care, if that wasn't there, that also seemed to discourage individuals from getting tested. I want to transition now and talk a little bit with you about some solutions in terms of another thing that really became a huge conversation at the time of COVID, and that was this issue around clinical trial diversity. You probably have also talked about that here, right? Clinical trial diversity, how can we better increase representation of racial and ethnic minority persons in our clinical research? And again, I'll say that community engaged research, this is not the goal of it, but community engagement is related to clinical research participation. And I think with the COVID experience, we saw trust is really increasingly recognized as an issue. I think it's an underappreciated social determinant of health. And there's research showing that there is greater distrust of researchers, for example, among African-American adults compared with white adults. And the distrust is partly driven by prior mistreatment by medical and research institutions, as well as concerns about misuse of data and research and other kinds of challenges. But one of the things that happens is these discussions about underrepresentation of racial and ethnic minority populations in clinical trials often focus on patient or participant level barriers, right? Putting the onus for achieving kind of diverse patient participation on participants just not being interested. When I think that what we should be doing is looking at the institutions, the research teams, the clinicians. We need to look inward to understand what we can do to overcome these major barriers, specifically at the interpersonal, institutional, and policy levels. And so it's possible to do this. And, people use the term cultural competence. It's not my favorite term, but I do offer that a firm understanding of populations and communities is really critical to doing this work. And it really goes beyond cultural competence to community competence. So, for example, trial teams should be sufficiently diverse in terms of perspective, experience, discipline, background, all of those things to really increase the richness of the work and to not have the blind spots that often can be there. And together, these teams can integrate and transform knowledge about individuals and populations into specific standards, policy practices, attitudes that you see in a sort of functional definition of cultural competence, thereby producing better outcomes, which is the goal. So if you are interested in this space of increasing clinical trial recommendations, I have a couple of three recommendations specifically. One is that we would want to see investigators set targets for inclusion a priori. And for people applying for NIH funding, you have to do that. You complete your planned inclusion table, but you want to do that in meaningful ways and thinking about how you should do that by race, ethnicity, as well as by sex and gender. So we should be thinking about this and setting the targets at the outset. There are benchmarks, and you have to think about your scientific questions and what's appropriate in terms of looking at a benchmark. It might be based on census representation or it might be based on burden for certain diseases, conditions, or behavior. So we want to think about that. If you wanted to do it based on census, for example, now these are 2020, we'll soon have next census will be 2030. And we know that the OMB categories for race ethnicity have now been changed. So we'll see some differences here. But if you were going to base it on US Census, then you would have to seek racial representation that is equal to at least or exceeds these populations, these proportions. And same thing if you were going to have benchmarks based on census for Latino or Hispanic populations. So that's the first recommendation. Second recommendation, focus on the factors that motivate individuals to enroll in trials. Look at the reasons that people do participate in trials. I think that that's researched far less frequently than the obstacles and the barriers to participation. So this table includes some of the, commonly listed, if you look across the literature, patient level motivations for participating in clinical trials. So positive staff interactions, the diversity of the staff, if the protocol is simple, if the flexible schedules exist that are convenient. People like the idea of getting access to cutting edge care, which I think we don't emphasize enough that could be a real benefit of participating, for example, in a therapeutic clinical trial. No cost medication or vaccine, and knowledge that there are research protections to assure participants' safety. And then my third recommendation is to address in a proactive way the known reasons for low participation in clinical trials among racial and ethnic minoritized groups. And most of the reasons in this table are not patient level factors. Most are interpersonal, institutional, or within the control of research teams. So a few of the reasons: lack of staff diversity, the fear of being experimented on. People say, I'm tired of being studied. Cultural incompetence, placebo group concerns, safety concerns, institutional distrust. And I think as we launch our clinical research and our trials, it's also important to remember that the team should be prepared to change and be nimble with your recruitment and enrollment strategies. Sometimes you have to do this many times across the accrual period to achieve the a priori targets that you set. I also want to address the key misconceptions are just important on this topic. We have to recognize, and there are well-conducted trials that show that racial and ethnic minoritized persons in general are just as willing to participate in clinical trials. So we have to dismiss this notion that racial and ethnic minority groups are just not interested or just hard to reach. I really detest calling groups hard to reach. Instead, the approaches need to be modified. We need to think that instead of labeling groups as hard to reach, it's incumbent on us as researchers and as institutions to consider maybe that the best approaches to reach certain communities haven't been identified, or we haven't been implementing them, or that the healthcare system has not done enough to ease the minds of populations around research. So it's really important that we address institutional distrust as opposed to kind of that automatic response of, well, there's just a lot of distrust or mistrust in communities. And how we get there is an empirical question in some ways, but I think that we have a lot of information about it. And I won't read all of these things, but we know that the research team, I suggested some things about the importance of the team and its multi-sector partnerships. And then there are a number of strategies that the literature has identified. But I think one critical one is the one I want to point you to at the bottom, number 7 under strategies. Number 7 under strategies that is almost certain to increase the diversity of your clinical trial is just ask. Just ask more patients from all groups, especially the groups who you believe are underrepresented in your work, if they'd like to participate. And then do what's necessary to make that possible. And have incentives that are not only individual, here's $20, but show them the community benefit. If you ask, people will participate. I do want to say something as I look to conclude here about the training area. I mentioned in our mission of NIMHD, we're very interested in supporting the development of a diverse and well-trained research workforce, that next generation of biomedical researchers. So we do fund a multitude of opportunities in the F award space and the K awards. We also really view our diversity supplement program as a real opportunity to contribute to the new investigator cohort. We know the importance of a mentored research experience, and we are focused on postdoctoral students, on new investigators. So anyone that has an R01 in this space, we're asking them to think about how they can bring diversity supplement applicants into the fold. And I would say the funding rate for these really is quite strong, especially when you think about comparison to something like, you know, an R award. Now, HDRI is one of our flagship training programs. It's the Health Disparities Research Institute. It is focused on postdoctoral fellows, junior faculty members, or early career investigators, I should say. And it's a really great opportunity. It brings people to campus, to NIH in Bethesda in August. Usually it's early August. And it had been virtual, but as of last year, we're back in person. The mock grant review is one of those key areas that people always say they really enjoy coming and having that experience of what's it like to sit through a study section. And so that's really important. And also just hearing about cutting edge health disparities research, engaging with NIH program officials. People even have the opportunity to get consultation on, you know, a developing research idea or strategies or methodologies for things that they're interested in. So this is a picture of the last year's August. We're approaching the 2024 HDRI. We're looking forward to that, just sending out the acceptances this week. But this is from our last group, you know, really strong group of diverse in discipline, degree, geographic location, sex, gender, race, and ethnicity, all the things. And it'd be great to have more folks from the University of Buffalo there. The applications for these for the sessions for this institute usually open in February or March. So please look out for that and consider applying or consider referring other people. The announcement, I think, will be out in December. All right, so just to wrap it up, we have to stay focused on this area because the really significant scientific and treatment advances that have been made have not benefited all populations in equitable ways. It is a wicked problem. And it's beyond time that we kind of accelerate the progress here and move it forward. You know, we have to have first and second generation health disparities science. We have to know what exists. We have to know how to explain it. But then we need to move to how do we address it? And that's third generation health disparities science. And at the fourth generation, it's applied to health equity lens. It's that we do it with all kinds of studies. And we think about how we can scale to the population level when we have efficacious and effective interventions. And from where I sit, that's where we need to go. So we need to bake in equity. It's something, it's just, I think about it as ingredients, just put in everything you do. Think about who's going to benefit, who's likely to not benefit. How can we proactively address these things? How can we evaluate and reevaluate on a regular basis to make sure that we are being equitable and applying that lens to everything we do? Getting there will help us reach this aspirational goal or this assurance of health equity for all populations. And that's definitely what we want to stay focused on. We are having a meeting next month in about 5 weeks here at NIH. Want to invite you all. It is part of the NIH Unite initiative. It's a 2-day workshop at the Natchez Conference Center at NIH on July 18th and 19th. It's focused on addressing structural racism in health using interdisciplinary approaches. It's going to bring together a really interesting group of people who are not always the usual suspects. Who have NIH funding to really talk about this. It will be hybrid for those of you who are not able to travel in. There is a website we have, it's called Ending Structural Racism at NIH. It's the Unite website. I'll make sure to send this to Jill so that when the registration opens, I think this week or early next, you will have a chance to mark your calendars and look at registration for this meeting. Always look at our website. NIMHD has a website with all of our funding opportunities. This is a small selection that they're active, so I just selected them just to give you a flavor of some of the things that we are asking for in terms of funding. But you can send us any applications. It doesn't have to be something that's in an RFA or some specific NIMHD solicited topic. Any good science, we want to see those applications. We want to see those from all of your faculty as well as your trainees. I'll stop here. I do encourage you, if you're not already following us on social media, please do that. If you want to sign up for news from NIMHD, if you go to that last public.govdelivery.com, if you go to that site, you would see for all of NIH, the different options of other institutes you want to follow, what kind of information you want to receive from them. But we have an active and growing listserv and audience, so we send out a lot of information about what we're doing and about what's happening and about the science that we support. So I invite you all to do that. And I thank you so much for this opportunity to present today.
Thank you so much, Dr. Webb Hooper. We really appreciate that overview. It was excellent, excellent. We have a lot of people here in the room. We have people on Zoom. Any questions? We have a few minutes.
Hello, everyone. I'm Broderick Kason from Univera Healthcare. Great presentation. Thank you. I just would like to make a comment on your discussions around people being able to be better connected in the community around community engagement. And I think that there's always been a struggle around how to do that. So it's like we know what the what, where, why, and who is. It's always how. So I wondered if you have any resources or any feedback on what are some of those real significant grassroots ways to do that. I think we know what those are. I think we've tried a lot of that stuff. I think we know that health fairs don't work. Generally speaking, they're a great opportunity to bring people together and get free stuff, but it doesn't really change the dynamic of what people really need. So what are your thoughts on that?
That's a great question. And actually, I appreciate whoever changed the camera view so I can see the room. So that's really cool. So, I think you're right. There are a number of ways to do this. I've actually found health fairs to be it depends on what you're doing it for. So if you're conducting, and I kind of alluded to this earlier, but I'll just make it a little bit clearer and concrete. If you're talking about community engagement, I see that, or like public engagement, community, I see that as giving information out, giving it, what you would do at a health fair. You're giving out information here, take a keychain, take this stress ball, and learn about our breast cancer screening program. That's community engagement. You want people to be aware, get information. And that's great. And also that's a way, if you are conducting a study or wanting people to be engaged, you can also have an opportunity to talk to them about that more in detail in those ways. So those opportunities to be in the community and set up shop and have a table and to do that can be very effective because, people have the free stuff because people will come over to your table, right? If there's something that looks interesting, and that gives you an entree and a window to start talking with them about something, find out what's important to them. So I would not discount that, but it depends on the purpose of what you're doing that for. If you're doing community engaged research, this is a methodology to apply to the work that you're doing, any kind of work, I would say, if you want to engage people, and that's more about having partners. So you would have your multi-sector partnership. So at the table, you have your academic scientists, but you also have, and I call those the content experts. Let's say we're talking about breast cancer. So you'd have your oncologists, your breast cancer experts, your breast cancer researchers, but then we also want our context expertise, people who know what's going on in the community, who might work at a grassroots organization that focuses on women's health or that focuses on cancer. And I would, at that point, maybe set up some initial meetings. It's like any relationship or networks that you want to build. You set up some initial meetings with those groups, talk about what you're doing, hear what they are doing. And it's not a one-off meeting. It's a series of meetings that you would schedule to sort of build that relationship. You might do it over lunch to make it a little bit more social. I've had to do this in many different contexts so that people get to know who you are and they can see that you're not just there to advance your own career or your own science or your own project or your own agenda, but you're there because you actually have information that you think could improve the health of this community and you want to see them involved. The equity and the power dynamics is another part of this. If you're really doing equity work, that means you're addressing the power dynamics and you're thinking about if there's funding attached to it. Are we making sure that our community partners have an equitable proportion of those resources? And so we're not just giving them a few dollars so that they can help us recruit participants, but are they a part of the decision-making team? Are they reviewing our materials? Are they helping us interpret the data once we have it analyzed? Are they helping us disseminate? Are they there in a real partnership sort of way? That's more community engaged research. So even if they don't have the technical expertise, the way that the scientist might, they have very important context expertise that the scientists may be missing. And so they're sort of community scientists, if you will. Bring everybody to the table and do it in a way that's not immediate. You can't do it right when you need, there's a grant application coming out, it's due in 2 months. Now we start this. You start it now, start it today. You make those connections, you follow up with people, and it can be done. I just think that we don't always do it the way that we should and with the care and concern that we should, maybe because of the nature and sometimes of how we were trained as scientists, but there are ways to do this. There are people who do it effectively. What I'm looking for at NIMHD is for applications that I can tell are authentic and that it's not just they can really write a mean grant application, but there's no true substance behind it if I were to come to the community members and ask them about their experience.
Thank you, that's helpful. And your NIH list of those funding sources, I think we probably have to do a better job connecting with you to make sure that our community is aware of those. I mean, I don't know about other people in the room, but many of those that you listed were new to me. I just think that it's important that we try as best we can to get that information out. And your points you made about connecting was very helpful. I think that we're struggling to do that, and I think that soft money is a good thing, but it's also a bad thing in that it doesn't connect you with sustainability. So people chase money, and we find the people that we need to connect the dots to get the money, but then we look at what the outcomes of the money we spent was, and I'm not convinced that the money we take in gives us the outcome that we're looking for at the end of the day. So I don't know if you found that in some of your research, but that would be helpful to know as well.
No, I can appreciate that. I think I have seen that happen. And it's not easy. So I certainly want to underscore that what I'm suggesting, and if you're talking about doing community engaged work, well, it's not easy. The resources are important, right? People have to have the resources to be able to do what we want them to do. I think though some of the relationship building that occurs before the project comes into play. So if you see a funding opportunity of interest, what you want to do, for example, and some of the ones I listed and many others on the website, you look at when are the due dates for this? When does it expire? A typical program announcement might be 3 years. So maybe it expires in 2026 or something like that. So you have some time to say, this is an interest area for us. How do I bring a team together that might be interested in this area too? Look at what's required, look at what we would need to do, what would they need, what would you need? It's tough in a soft money environment. I think you should be submitting a grant application every single cycle, if not more, and have teams of people who are working on that together. I know that's ambitious, but it requires such a persistence to get these kinds of funds. But when you're successful in doing that, you have an opportunity to really do something important and meaningful. But getting together, having regular meetings, even in the absence of funding, to prepare yourself to be ready to go when something comes up that's of interest to you. And I will also say again that if you're interested in a topic that's not listed on our website as an active funding opportunity, that's okay. We are seeking more investigator-initiated ideas. So you bring your good scientific ideas to us, even if it's not something we'd specifically called for. We'd like to see more of that. We don't want our ideas to stimulate and motivate the field, but we don't want it to stifle or prevent you from, pursuing an idea that you think is important.
Thank you so much. So we have one more question. It's from Dr. Tim Murphy, and Tim is the Senior Associate Dean for Clinical and Translational Research. He's also the founder of the Health Equity Research Institute and the PI of our CTSI. And so I'm going to turn the mic over to him, and he's going to ask you the final question, and then we'll move on.
Thank you, Dr. Bashir. And thank you so much, Dr. Webb Hooper. What a great talk. Just a really nice overview of multiple important principles. My question has to do with implementation science. It's sort of the last step in one of your last slides. I think those of us in the academic world don't think about that very much. We think about, we get the big paper, get the big grant, and that sort of thing, and our work is done. And yet our community members ask us, well, how does your research benefit us? And my question really is, I can ask you, it's sort of a new and rapidly evolving science, implementation science, and ask you to comment, if you would, a little bit about your approach and NIMHD approach to implementation science, how you value it, and how, what you can tell us about that with regard to how we can improve in that area.
Great question. And it's true, it takes about 10 years from an effective intervention hitting the literature to possibly being implemented in a community or clinical setting. We are very committed to D&I research. NIH has a parent D&I dissemination implementation science funding opportunity on which we are signed on as participants. So that means that if there are well-scored meritorious applications that come in from that funding opportunity, or really any other, we would be happy to consider it. We also have one of our extramural scientific divisions is clinical health services research. And that's where we do a lot of our implementation science work. It's typically in the context of working in a clinical setting and translating our findings there and how do we improve health systems. That's where we see the bulk of our D&I work. But outside of that, we would support D&I in other community and other kinds of settings as well.
Thank you.
So thank you so much. We really appreciate your talk. I'm going to turn this over to Dr. Cizak.
Thank you again, Dr. Webb Hooper. We so appreciate the time that you spent with us and the support that you actually send to some of the University at Buffalo investigators, and just have learned so much. People were very excited to have you join us today.